Assalamu alaikum, respected chairperson and the distinguished delegates. Assessment of the right ventricular function is challenging because of its anatomy, distinct anatomy. And also due to the fact that functionally it is also astonishing. Because this is a slide from binding which shows the dead right ventricle. And it reminds me about The Dead Man Walking, the award-winning movie that shows a unique vision. So my vision about the right ventricular assessment is, right ventricle is mere and conductance. It does not have its own function. So it doesn't really matter whether right ventricle is alive or dead, it will be functioning. Because its function depends mainly on the left ventricle. And since it is a conduit, the free flow of the blood requires the free afterload. So two important determinants of the right ventricular function is right ventricular's dependency on the left ventricle and the afterload. So my talk will be confined on the right ventricular dependency on the left ventricle and the determinant of the right ventricular function. So this is a study done in 1941. The right ventricle of the dog was cauterized, and there was no right ventricle at all. But despite absence of the right ventricle, their patient showed no peripheral congestion. So they concluded peripheral venous congestion do not have any evidence that it is caused by the predominantly right ventricular failure. An elegant study also showing when only the left ventricle was connected with the electrical impulse, no connection of left ventricle with the right ventricle, there was pressure curve in the right ventricle and pulmonary flow. It again proves the independence of the right ventricle. We had a small paper, had an opportunity to show patient undergoing valve surgery and subvalvular aperture dissection and had some IVS, interventricular septal dysfunction. Some of this patient really showed bad right ventricular function. So let us look how it is important from the therapeutic point of view. When we reduce the preload, this septum moves close to the right ventricular free wall. The motion of the right ventricle depends upon the cross-sectional motion of the free wall of the right ventricle, which is not very important. But important point is the attachment of the free right ventricular wall with the interventricular septum. Actually, right ventricle drags down the interventricular septum, and it is the main force of right ventricular contraction. We know the longitudinal function of the right ventricle is much more important than the transverse section. So it again proves the dependency on the left ventricle. As regard the afterload, we know this famous curve, the pressure volume curve. Actually, with this pressure curve, we should estimate the right ventricular function. This is the gold standard of assessing the right ventricular function. The parameter that we need to know is the elastance of the artery, which is dependent upon the afterload, and we know the sum of the afterload depends upon the vascular resistance, vascular compliance, and the reflex wave. So again, coming back to this curve, this is the normal curve. Here the pulmonary valves open and here the pulmonary valve close. And when there is increased afterload, the pressure rises. And along with this rise of pressure, the contraction, the intrinsic contraction of the right ventricle also increases. So afterload is matched by the intrinsic contraction of the right ventricle. And when there is mismatch, what we know as right ventricular and pulmonary artery unit uncoupling, this is one of the very important mechanisms which is responsible for right heart failure. So the dependency of the left ventricle is not only, the dependency of the right ventricle on the left ventricle is not only anatomically. When there is increased pulmonary waist pressure due to left ventricular failure, it drags down the compliance of the pulmonary artery. not proportional to the pulmonary vascular resistance, much more less pulmonary compliance that we get when there is increased pulmonary waist pressure. So left ventricle has got very important role to play. And therapeutically, we know in 2018, it was stated, if we target the pharmacology and mechanical intervention, that is optimizing the LV septal function and optimize the ventricular interaction, that would have helped in right ventricular failure. But this specific therapy is yet to come. And now, till nowadays, we use right ventricular function only to know the prognosis. So let me come back to one of my case. 64 years old lady. This lady was having having diabetes. This lady was having this lady was having hypertension, diabetes, and had a CAG. We can see in this echo, he was having left atrium dilatation, right ventricular dilation, and if you can look at this portion of the septum, I told you that function of the septum is important. Here we can see the right ventricular the features of right ventricular increase after load. So when we went down, again, we can see the free wall, which is smartly moving, and this right ventricular do not look that bad. This patient also had tricuspid regurgitation. So we looked at TAPSE, and the pulmonary pressure gradient, and we found that there was TAPSE of 12 and increased pulmonary artery pressure. The increased pulmonary artery pressure, and obviously we look at the left ventricular inflow pattern, extremely high restrictive pattern of filling, and there was markedly reduced E prime, which suggests that the E by E ratio of 28, and obviously this patient had pulmonary capillary waist pressure of at least 30 millimeter of mercury. And if we look at this curve, we can see that when normally this patient's curve would have been, pulmonary volume pressure curve would have operated in this way. But when we have got increased pulmonary pressure, as we had for this patient, the curve will move like this. And every possibility that this patient was having uncoupling. So can we measure this uncoupling by echocardiography? This is an uncommon practice. But the study have shown the ratio of TAPSE and PASP, which is a very well marker of survival, distinct marker for survival. An elegant study later done in Japan, which again shows when the ratio is less than 0.36, there was marked difference in survival. So what we got in our patient, we had a figure of 0.22. Had this patient a TAPSE of 18, even then his TAPSE by SP ratio would have been 3.3, which is less below than the normal. So the usual measure TAPSE and the fractional area shortening really do not indicate how much the RV is failing. We can also, if you have the notch, we know that the pressure after load has been increased. We have other measures of after load, like when we exercise the patient and we don't get a response of pulmonary pressure, then we know the patient has got coupling. Coupling, the right ventricular ejection fraction as measured by three-dimensional echo also shows some coupling. So to summarize, pressure volume curve is important to know the RV function, and TAPSE by SPAP or right ventricular function are important prognostic factor. Here in this patient, we can see a lazy right ventricle. Naturally, this patient had very low TAPSE and very low S prime. And we measured the pulmonary pressure in this patient. You can see that the mean diastolic pressure, if we add left atrium, right atrium pressure of 28, it will be not much. And more important is this curve. This curve shows, this dome pattern shows that this patient do not have pulmonary hypertension, especially the acceleration time is so prolonged. So in our second case, if you look at the survival curve, this is our second case. The case which was showing a bad right ventricle apparently, and all the measures were as bad, the conventional measure. But when we look at the first patient, it was looking relatively smart right ventricle, but yet it had bad prognosis. So we had little uncommon practice to know what is really happening in the right ventricle, and we know which is really happening mechanistically in the right ventricle. Thank you very much.
Thank you, sir, for your brilliant presentation. Now we have 3 minutes for a question and answer session. If anyone have any question, he or she can ask from his or her own position, and mic will go to him or her. 3 minutes for question and answer.
Sure.
So Mike. Can you tell me the practical points of measuring the RV function in day-to-day echocardiography?
Sir, TAPSE and right ventricular fractional shortening is important, but in my presentation, I have shown the measurement of the pulmonary pressure as well as the ratio of TAPSE and the systolic pulmonary pressure is what really indicates the real RV function. In day-to-day life, TAPSE is the most important measure, but we have to keep in mind TAPSE really all the time do not represent the true RV function, as we have seen in my 2 cases. Looking at the right ventricle is important. Looking at the function of the septum during systole and the ventricle is important. Looking at the downstream pressure of the left ventricle, which is important to know about the function of the right ventricle, which is important. Sir.
My question is, the pulmonary artery pressure that we measure, will it be at rest or during stress?
It is a good question, sir. It can be normal in the rest, but if we exercise the patient with bicycle ergometer, and if the patient have an increment of 30 millimeter of mercury, then we know that patient is not having uncoupling at least. And if the pressure crosses, systolic pressure crosses 50 millimeter of mercury, then we know that this patient might have latent pulmonary hypertension. We measured this pressure during rest.
I want to know about the application of 3D, because you know the RV is a very complicated structure. So when role of 3D and TAPSE only measure the longitudinal contraction of the tricuspid annulus. What about the RV strain? Because it looks for the RV mechanics. So role of 3D and the RV strain.
Thank you, madam. Absolutely. 3-dimensional right ventricular function measured by the 3D echocardiography is the gold standard, we know. And it also reflects the uncoupling, the main mechanism which is responsible for right ventricular failure. Absolutely, right ventricular ejection fraction measured by 3-dimensional echocardiography is very authentic. But as regard the RV strain, there is no robust evidence at least, but some studies, at least one study was showing the relation between RV strain and the survival curve. Why we do all this RV function? Right at this moment only to know the prognosis. There are no other role of knowing about the right ventricular function other than knowing the prognosis. So prognostically, the RV strain is important. It denotes some prognosis, yes.
Okay, thank you. Yes, RV strain is very important for prognostication of heart failure patients. Thank you, Chaudhury Meshkat, for a nice presentation.
Thank you, ma'am.
Dr. Nasrullah.
Assalamu alaikum. Meshkat bhai, wonderful presentation. Learned a lot. Thank you so much. A simple question. A lot of time we see that RV function is impaired, PSP is high, and we give drugs like, taldolafil, bosentan. Is there any role of these drugs in RV malfunction with raised PSP? Clinically?
When we have group 1 pulmonary hypertension and idiopathic pulmonary hypertension, PDE5 inhibitor has got some role in reducing the pulmonary pressure. And if the pulmonary pressure is decreased, after load is decreased, there is some improvement in the right ventricular function. But if you consider the left heart failure and pulmonary hypertension, the RELAX study has shown no benefit of PDE5 inhibitor in those patients. Also, there are some different ideas that at a time, especially patients with HEPF, do have precapillary sort of a reason for pulmonary hypertension. We can have some data in future to see whether by applying PDE inhibitor that act on the precapillary mechanism could be beneficial for HEPF patient or not. But what happens with these SGLT2 inhibitor is, it has been shown that they really help in uncoupling and make some vasodilatation in the precapillaries, and so that they are helpful in HEPF. Thank you, sir.